No question.
Okay, thanks. All right, and then you know what I might do is I'll just let you know when you have about 5 minutes left and then 2 minutes left, just so you're kind of kept on pace. And I'll start my timer in a little bit, and we'll give you 20 minutes.
Okay.
Okay, are you ready?
Yes.
Okay, let me mute myself, and we are recording, so go ahead, take it away.
All right, my name is Anna Buchting, a CNS student from Azusa Pacific, and today we're going to talk about prevention of new or worsened pressure injury at Barlow Respiratory Hospital. Pressure injury is a big concern today in the healthcare system, and unfortunately, most of them can be preventable. So today we are talk about what are the best practices to decrease these pressure injuries. Pressure injury is injury that is caused by pressure to the skin and the underlying tissue. Previously, before 2016, the pressures has been classified as an ulcer according to the level from 1 to stage 4. But there was another injury called deep tissue injury that is when the skin is still intact, but it's damage under the skin. So that became a questionable that doesn't qualify for definition of pressure injury. So that's why they changed the name to pressure injury instead of pressure ulcer. So hospital acquires today the concern. Patients who come to the hospital and get damage to the skin and become with a pressure injury are called hospital acquired pressure injury. Before was called hospital acquired pressure ulcer. So today through the studies, through this thesis, we're going to talk about HAPI or PI instead of PU or HAPU. And what is a clinical nurse specialist role? CNS or clinical nurse specialist is an advanced practice registered nurse who has been integrating the care through the continuous hospitalization and even after. So they influence patients, they influence nurses and administration. So they are a key role in all this process for the care. What are the background for this thesis? Today, more than 2.5 million patients suffer PI in the United States. That is a lot of patients, and all this costs money, cause pain to the patient, can cause long-stay hospitalization and families damage. So pressure injury, for example, worldwide is a prevalence of 10%. From every 100 patients, 10 of them have pressure injury. In the United States, it's 11.5. Now, in a long-term care settings, that is where the patient stays for a longer period of time, is up to 38%. So you see the difference in these numbers. Today, this review, or this literature review that I did is to apply at Barlow Respiratory Hospital. And what is Barlow? Barlow is a long-term acute care. It's different from just long-term. It's a patient who are not critical enough to be in ICU, but it's not quite steady enough to be in a long-term care. So they come to the acute long-term care. That is a Barlow Hospital. They are medical complex, but it's still a reasonably compensate. So this kind of patient, because of the medical complex, they are a higher risk for developing pressure injury. So this review that I did about the pressure injuries, it tells me that at Barlow, patients who come to Barlow are with a case mix index, CMI. That is how they measure how complex the patients are, medical complex. So a Barlow is 1.3, while national-wise it's only 1.1. That's how, tell me how severe is these patients are, so of course, higher risk to develop pressure injury. At bowel patients, upon admission, they have 60% of the patient has some kind of DTI. DTI is a deep tissue injury, while national average is only 18. So there is a difference between 60% and 18%. That's why it's a concern, especially for a hospital, how we can prevent this wound of getting worse, or how we can prevent it happening. Just a stage 1, that's the first, the mild stage of pressure injury is 48% of bowel, while national-wise is only 8.2%. So we did a review of, this review of the literature reviews different database. Some of them was CINAHLA, PubMed, Medline, and some Google Scholar. But we found a lot of articles, and we chose those in English, and the inclusion criteria was English, adult over 19 years old, and the articles that were in the past 10 years. We used the keyword pressure injury or pressure ulcer, and best practice and prevention of treatment. We end up with 15 articles that we review, and we try to get what the best practice they do. Just to remind that bowel also are patients respiratory hospitals, so around 42% of these patients who come to bowel are also compromised respiratory-wise because they are on vent. 42% of the patients are on vent. So it's another risk for developing PI for the poor oxygenation. Sorry. So with reviewing the literature, there is multiple studies, and a lot of them have different categories. So we try to categorize in these 7 topics. Some of them, for example, in the risk assessment, skin assessment, what are the preventive strategies, and the knowledge. And on the risk assessment, some of the studies, for example, I think it was Collier, he reviewed the risk assessment scale. The one that have been used is the Norton, Waterloo, and Braden. Bowel used Braden scale. And he did a study with the different 3 of them, and then see what is the best ones. And those are the 3 most usable. When the nurses are doing the risk assessment, they evaluate what risk the patient has. For example, mobilization, how mobile the patient is, how the moisture level. They check the nutrition level, the sensory perception, the oxygenations, and so what are the risks, and which ones are my priority? What strategies can I use? Some of the studies were comparing, and that they had seen that sometimes the new nurses underestimate the risk of this patient. So a little more knowledge, a little more knowledgeable will help with, to have more knowledge will help with these patients. The other studies are also talking about the skin assessment, how soon the nurses should do the early detection, the better. So they're gonna assess from head to toe and then see what stage the wounds are, if they bring, and if they didn't, then what we should do. So there is a connection between the risk assessment they do, the skin assessment they do, and what preventative strategies they do. So some of the studies, for example, they did the connection. So they says the nurses sometimes do a good risk assessment, but they don't do a good preventive strategies according to what the assessment was done. So we need to improve that. So the studies, the different studies are talking about different points. So coming with the best preventative strategies, some of them are, for example, the frequency of turning. Even today, there is no specific timing how often we should turn the patient. But some of them were talking about, we did some randomized trials. Some of them were turned every 3 hours. Some of them were turned every 4 hours. but we did compare also what surface we use. So we use a foam and we use a regular. So they have all the studies at the conclusion, they said that 60% of the patients had decreased the PI if we use the foam mattress instead of regular mattress, and we turn every 3 hours. So that was the evidence they did in that study, but still more research needs to be done. Another strategy is in the frequency of turning was the angle, how some of the studies were doing the 90-degree angle and other ones were doing 30-degree angle. Between those two, they said the 30-degree angle tilt is better than the 90-degree because decrease the pressure and the oxygenation in the tissue. So this is another studies that lately has been the best. Another ones are the support surface. What kind of support surface? Some of them, I says the foam is better than the regular, but also if we use the air static layer on top of this foam is even better. And then the other one says, another study says, well, if we use the airless mattress, it would be even better because the air release some air into the patient, and then it keep the patient more dry and cool, because it's releasing some micropore airs into the patient. So it's even better. So all these studies, we try to get what are the best ones to use in our hospital. The incontinent skin care, as usual, has been just to prevent, use the skin barrier creams to prevent from and then also the silk, like a silk sheets, also because those surfaces will prevent from shear and friction of the skin that preventing damage of those skins. So they recommend that these ones are better. Some of the other studies also was randomized trial. They did a dressing for silicone, 5-layer of silicone dressing that they put it in the sacrum area and the heel area because they said they are the higher more prone to develop pressure ulcer. So they says that if we use it as a preventive, even though the patient didn't have any pressure, but we put it as a preventive, it has decreased the pressure, also developing pressure injury. So that's was a good one of my got my attention during reviewing this literature. There is new emergency evidence also, and that one was the polarized light. They use polarized light for 10 minutes in this area for high-risk developing pressure injury and has seen that it helped. Also, the CBMP, that's continuous bedside pressure, it's a continuous continuous bedside pressure mat. So what they do is they put a mat with a sensor inside and then under the patient, and they are controlled by a monitor. They are watching monitor with a monitor connected, and the nurses are able to see. They're going to highlight in different color. If it's red, that means the pressure in that area has been more than 180. So it's time to change the position. Nurses like this kind of device because it helps them to prioritize. So hopefully in the future, we're going to have more availability and more studies done with that. The other part of the literature review I did was knowledge, nursing knowledge and attitude. There are some tests that can be done, like PUKAT, some tests that you can test the knowledge, how much the nurses know and how much they can do for the patient. So that was another topic, very interesting, that they have found that experienced nurses are a different approach in compared with the new nurses. So we need more training. We need more knowledge in these nurses to know the early detection. Patient education, that influence also when the patients are there, the families are there, they will help more with all these preventive strategy if they know more. But the studies, most of them show that the patients are not well educated in prevention injury. So we need to enforce that one too. Increase the awareness. So just once we educate the nurses, when we do use all the preventative strategies, we need also to keep that maintenance, keep awareness of the patient can develop pressure ulcers. So they recommended some theme songs, some stickers in the door, so we are aware that those patients need more attention. There are different pen lights to recognize nurses who are champion, who do a better job, healthy competition among the staff. So this encouragement, this awareness, it will help also to with the pressure injury. And of course, the simultaneous treatment of the wound. That is a completely different topic, but I include a little bit in this literature. What is my gap in research? There is a lot of gaps still. A lot of, like I have been mentioning, there is a reposition. There is not definitely a study that says what every 2 hours is the best. There's still nothing in there. They have been doing a study, but there is nothing finalized. For skin failure, there is a lot to do. Nurses still don't know what is the difference between skin failure and DTI or pressure injury. They're still treating the same. So more research needs to be done in all these areas. What nutrition have to do with pressure injury? What are the markers for prognosis of the patient going to develop DTI, pressure injury? Of nutrition, of the nutrition, what are the markers? They use prealbumin, they use serum albumin as a guide. Oh, this patient may develop wounds because the prealbumin is low or the serum albumin is low, but it's not definitely. That's what we have up to now. My related topics that I think was important, when we approach patients for a DTI, we have to know that also pain is related to DTI. We need to treat these patients' pain to improve the quality of life. These wounds may develop pain and also will be uncomfortable, but patients need to be treated pain management. It has to be part of the goal for wound healing. Socioeconomic status also, a patient has wounds, they are impaired socially, they cannot use the shoes that they need to wear, they would like to wear to go to a social event because of the wounds. So wounds affect socioeconomic also status for this patient. The patient develop wounds, it's gonna cost more money for the hospital, it's gonna cost more money for the patient when they go home to treat it because they need more care. So it affects pressure injuries affect socioeconomic status of the patient. Nutrition, like we talked before, is also another big part of the wound healing. The theoretical framework that I used was Ida Jean Orlando. Orlando was a nurse who developed this liberating nursing process, nursing theory in 2000, was posted in 2016. There are different stages: assessment, diagnosis, planning, implementation, and evaluation. So I thought this one will be a very good frame for this review. For example, the assessment. Part of the assessment will be when the nurses start assessing the risk. Okay, this patient has this and this risk. We need to collect this data to develop what risk level it is. Is low risk, high risk, moderate risk. Once they have the risk that, okay, this patient the nurses do the skin assessment. Okay, we're gonna find out if the patient has wound, doesn't have wound, and they're gonna do a judgment to confirm the diagnosis. Then we're gonna plan what my intervention is gonna be. I'm gonna plan this patient is a high risk. I'm gonna plan this intervention. My goal is to not to develop pressure injury. What about implementation? Okay, put an air loss mattress, put the degree 30 degrees turning every 2 hours, every 3 hours. I'm gonna maintain the patient dry. I'm gonna put the skin barrier protector and all my implementation. And may I do my evaluation, daily assessment to see if what I did is improving or not. The advantage with this theoretical framework is that it can be, it's universally applied in nursing, because even though it was developed in psych units, it can be applied in any other settings. And the other advantage is that it can be adapted. For example, if my wound is not getting better, so I can back up and says, okay, this implementation, I need to change it for reach my goal. So it can be adapted at any or modified at any time. Now, what is the CNS role? CNS play an important role. Clinical nurse specialist is a connection between patient, administration, and staff. So the CNS is gonna bring what are the evidence-based practice, what are the new guidelines that is gonna help my patient to develop, to prevent pressure injury. They are part of the leader team, the administration team, to influence and develop these policies and plan. They go into the patient because they are watching the patient from the beginning to the end. They can intervene with the doctors. They can advocate for this patient. They talk to the families, and they also help the staff. If the staff don't have the knowledge, they're gonna help the nurses to develop this knowledge that is needed to help the patient. So they are a key role. The CNS has many domains, and they can be as a consultant. They can be collaborated with the team, with the nutritionist, with the wound nurse, with physical therapy, with the doctors. They can be also a leadership. The leaders, they're gonna lead in this. They're gonna lead in this project to prevent the pressure injuries. Also, they're gonna be coaching the nurses, the staff to do a good job. They're gonna do research because they're gonna try to get one of the best evidence-based practice. Also, direct patient care. They're gonna contact with the patient. They're gonna be in contact with the families, and also they can be part of ethical decision making. My proposed interventions are for ball low, since we are a high-risk patients, they can develop wounds, so it's a lot of work to do. So I propose that we develop a plan including all these interventions that I have. For example, to continue to reinforce the education with the breakdown scale. We use the breakdown scale to make sure that the new nurses and are using it appropriately. We can do some evaluation. We can monitor if some exercises with these nurses, and to see the head to toe, they have recognized early signs of skin damage. This one, we can work together with the wound nurses to implement the best strategies. They have from between 4 to 8 hours, according to the guidelines, to do this assessment. So we're going to continue to monitor that. Another proposed intervention will be to use and the preventing strategies is to encourage to do the 30-degree tilt for turning, and according to the need of the patient, evaluate how often the patients need to be turned. At Barlow, we are doing every 2 hours right now, so continues encourage that, but focus on the 30-degree. Also, the flexibility or the protection of the heel, to be elevated, to use something to prevent from the damage, and the dressings. Use the preventing dressing, the silicone foam in the sacral area and the heels. Up to now, we are not doing that yet, but I will encourage to do that to prevent the damage in this area. And maybe in the future, we have more availability of this polarized light that may help us to also decrease the pressure injury. With regarding the nursing knowledge, I will also, we can work together to see how we can evaluate up to now what the knowledge are and how we can improve these areas. One of the suggestions is to develop the bundle intervention. Bundle is organized interventions, grouped and structured into according to the risk of the patient. Some hospitals, they are doing that, and nurses like this this proposal. So we can talk to the staff regarding about this bundle intervention. Another ones that with the patient education to encourage more. Up to now, very weak this topic in patient education. So They focus on education in other medical issues, but the wounds, we need to encourage more of that. So that's another area that I will work on that. And of course, continue to increase in the awareness. We would suggested, this study would suggested that also to do the stickers. So we know that patient is a very high risk to develop pressure injury. We focus and monitor closely. I'm gonna also do the healthy competition to post it, the best staff who has been working to prevent pressure injuries. Hoping to reach these outcomes. The outcome is in short term, medium term, and long term. There is improve the knowledge in the nurses. Continues doing frequent auditing and evaluation. We are using the PDS cycles program right now, so we're going to continue doing that and to be part of the success of this program. Hopefully by December we have been decreased the rate of by 50%. Hopefully, all the hospital-acquired pressure injury, and also developing an application for Joint Commission as a disease-specific certification by December. The Joint Commission has this program that certifies hospitals for a specific disease, and this is one of the outcomes that we'd like to reach soon. The medium term will be after we apply, they're gonna come and certify, do a survey and evaluate, and then do the certification. So that would be the medium term to reach this certification. Also, be one of the in the states, Bal to be one of the state leader of with a low rate of hospital-acquired pressure injury. And in a long term will be the patient safety and priority, and then hopefully nationwide leader in hospital-acquired, less hospital-acquired patient. My implications, the implication for practice is after this program has been developed, then there will be a constant monitoring of the progress. Barlow will have a disease-specific certification by Joint Commission, and then we'll need to keep improving the outcomes to keep this certification. We'll maintain also the best patient's outcome, being the leader in wound care. And we might participate in research programs. At the end, the purpose of this one is to have for Barlow a high frequency of the conclusion is that after this one, Barlow will have a significantly high decreasing frequency of pressure injury and the number of patients for developing pressure injury. We would recognize, the nurse is going to be able to recognize early enough to intervene quickly and decrease the pressure injury. Working together with nursing, nutritionists, physical therapy, doctors, administration, I know we can do it. We're going to increase the awareness of the staff about to prevent early enough pressure injuries. We're going to work together to make these changes for the sake of the patients, and also a hospital will benefit with early decreasing the financial, and become a good competition with other hospitals. So we're going to be attracting payers, attracting doctors and providers. That would be it. Thank you.
Yay. Great job, Anna.
Sorry about the interruptions.
We didn't save too much time for questions, but let's see if Dr. Santiago has any for you.
Yeah, I think you had a good presentation from what I could follow, but I just had one question for you. Can you hear me?
Yes, yes.
Okay, good. You mentioned a lot of interventions that would relieve, improve pressure injury rates. A lot of that is already known by by nurses and physicians and the healthcare team. But what do you believe was still causes patients in many facilities to continue to have high pressure injury rates despite the knowledge?
Yes, that's what is called unavoidable pressure injury. And that's what I was talking about, skin failure too. So there are some small percentage that is still unavoidable. Those one we won't be able to do it. But most of them, we can do something about it. So that's
Right.
a good point. That's a good point. It's still gonna be there.
So even though a lot of staff are implementing the measures that you mentioned, a lot of hospitals still continue to struggle. So what do you think the cause of these struggles are besides the unavoidable pressure injuries?
Well, if we don't talk about the unavoidable, there is a prevention that the nurses should be working with. We have monitor, because I have experience in wounds. I know we can do it. I know that doing frequent monitor and encouraging the nurses to, for example, the turning, the skin damage, and the pressure, the dressing change, the prophylactic dressing. I know we can decrease it. A lot of study has said that they have been able to decrease. I don't know if that's what I'm trying to.
What I'm getting at is that there's two things. There's two ways you gotta look at staff, and this may be from more of a management point of view. Is that sometimes it's a knowledge problem where the nurses lack the skill to properly take care of the patient, but sometimes it's more of a will where the nurses have the knowledge, but they are then not convinced that they need to change their practice enough to make a difference. So I think that's something to consider when implementing this in a real practice.
Well, I think what some of Anna's slides show that nurses are lacking knowledge, that they don't, even though you know all of this, the studies that she showed when they looked at nurses, right, Anna, that they didn't have all the knowledge that they needed.
Yeah. If they don't have all the knowledge, certainly the education and reinforcement come into play. But I think you've got to have the combination of both aspects of skill and will to be successful in a
Yes.
in a like this.
Yes, you're right. The knowledge, because before even the doctors, sometimes you tell the doctors what you want to do about this one. I said, talk to the wound nurse. So wound care hasn't been the priority to teach the nurses. So it's a job, especially Barlow wants to reach the joint wound certification from Joint Commission. I think knowledge hand on hand with the nurses work together to get that decrease. Another point, also the nutrition. Remember, so nurses need to know that the early intervention of the nutritionist is also important. Early intervention, early mobilization is important. So all these keys the nurses need to be aware, and the only way is doing service, work hand on hand with these nurses.
Thank you. I've got to get going, but a great job.
Thank you.
All right. Have a great evening.
Thanks. Bye. Anna, what does the Joint Commission say that you have to do in order to become certified? Did they say you should do 30 degrees versus 90 degrees, or turn every 2 hours versus 3 hours, or use this kind of mattress or this assessment? Like, do they have specific criteria about what you guys will have to do at Barlow in order to get certified?
Yeah, the application is online, and then we fill it up to see what are we doing all up to now. We are doing the PDS cycle, but also they want 4 measures, something that they can measure with improvements. So we are thinking about the documentation of the nurses and Meditech, something that we can about the nurses documentation and the wound care documentation if it match. So for example, we have a special camera right now that camera take a picture of the wound, and the camera, it will measure how big the wound is, how deep the wound is, and then we take a picture every week. So the next Monday, we're gonna take another picture, and the camera as a software is gonna measure and graph if the wound is improving and is decreasing or is worsening.
Mm-hmm.
The camera will give us that measure. Okay, this you can see 90% of the wound has been improved. You see so that is one of the measure, the documentation of the camera with the Meditech is the system that we documented. The other is the marker, nutritional marker. We are talking about the nutrition will be evaluated, how the patient within 5 days, how the nutritional level of the patient, how much calorie, when the patient arrived was poor or not, and how is it the 5th day. For example, when he came, the calorie intake was maybe 1,200, and by the 5th day is already 2,000. So there's something that we can measure. That's another marker. I forgot right now the other two markers. I think it was
albumin. Did you say
the admission and the discharge? How many wounds the patient came with, and if he came with wound. At the end for discharge, how was the wound? Is a stage 1 or is get better? So that's another measure we're gonna submit. It's a 4 measure that we're gonna measure. So we're
I'm sure just filling out the application, you'll learn about a lot of things that the Joint Commission says is evidence-based and is not. So.
Yeah, like I said, the turning, for example, the turning is something that we are turning every 2 hours because that's the guidelines. We follow the guidelines that we have up to now, although in November they're gonna come with the new guidelines here. But there is no set says, okay, this is the best. This is the best practice for turning. We don't have nothing yet.
Okay.
But the practice says every 2 hours. So we'll see what other.
Good.
I think we are in the process right now of submitting the reviewing the application so we can submit it as soon as possible. So we have a meeting actually tomorrow.
Oh, good. Well, I think Barlow is very lucky to have you working on this problem, especially with the incredible prevalence you have of these, and it's amazing that it's so much higher than the rest of the country.
It's unbelievable.
Yeah.
I have been with Barlow for 15 years, and I tell you, the wounds get better, but you have to be on top of the nurses. Really help.
Right. Yeah, it's hard determining priorities when there's so many competing demands.
Yeah. And now actually Medicare won't pay you for if.
Right. Yeah. Okay, well, that's all I have. I am going to stop recording.